Welcome back to the deep dive. So if you're prepping for those big exams, maybe the AKT, or honestly, if you just get that, looking after people at the end of life, doing it compassionately and safely is maybe, well, one of the most important things you'll do as a doctor, then this deep dive is absolutely for you. Today, we're not just, scratching the surface of palliative care. We're really drilling down. We're talking core protocols, the actual dosages, the safety points, the stuff that takes you from just knowing about it to feeling confident, actually doing it in practice.
Yeah, that's spot on. And the sources we're looking at today, they're really built for that, for quick recall, making safe calls when you're under pressure. We're moving beyond the general ideas, aren't we?
Exactly.
We're getting into the nitty-gritty, how you actually work out opioid dose changes, those crucial kidney safety checks, and, the immediate steps for those really scary oncological emergencies. We've got to nail down the protocols because that's what makes the difference, sometimes on an exam question, but much more importantly for your patient's comfort, their dignity.
Right. So the mission today is clarity. It's application. You need to be able to pull out instantly the difference between, say, hyoscine hydrobromide and butyl bromide, or know exactly what to do for hiccups that just won't stop. By the time we finish this, you should feel totally solid, not just spotting a palliative issue, but knowing the precise step-by-step plan from the guidelines. We got a fair bit to cover, so let's jump straight in. The bedrock of it all, managing pain. Okay, let's unpack starting strong painkillers, the opioids. When we begin, the standard way, the really careful way, is starting with immediate release morphine, IR morphine.
Yeah.
We use that IR form first, don't we? Because it lets us see quickly if it's working, check for side effects over a short window. Only when things are stable, we know what's needed, do we think about switching to the long-acting stuff.
And that switch, that's where people sometimes, get a bit lost in the numbers, but it's actually quite set out. It's a protocol.
Yeah.
When you go over to the modified release, the MR form, the usual starting daily dose is pretty specific. You're typically aiming for 20 to 30 milligrams twice a day.
Okay, 20 to 30 milligram BD.
Exactly. And that range, it kind of balances being effective for moderate, maybe severe pain, but also respects that patients might get side effects at first, especially if they haven't had opioids before. You'd probably lean towards the lower end, maybe 20 milligram if someone's elderly or a bit frail or hasn't had much opioid exposure.
Okay, so let's say we start someone on 30 milligram MR twice daily. That's 60 milligram total over the day. Straight away, we had to put that safety net in place, right? The breakthrough pain plan. And this isn't just a suggestion. It's a strict formula.
Oh, absolutely. It's like the anchor point for safe prescribing here. For breakthrough pain, that rescue dose, it has to be prescribed as exactly 1/16th of the total 24-hour MR dose.
Yeah.
So using your example, 60 milligram total MR daily. That means the patient gets 10 milligrams of IR morphine for breakthrough episodes.
Right, 10 milligram IR.
And that ratio, it's not just random, it's worked out scientifically. It gives enough of a top-up for those flares of pain, but without causing, huge peaks of sleepiness or toxicity, especially because they're already getting that background MR dose regularly.
I see. So the ratio keeps the dose relative to what their body's already handling.
Okay.
Now what happens next? The patient's on their regular MR dose. They've got the 16th rescue dose available, but they're still in pain. They're using lots of breakthrough doses, which tells us the background control isn't quite right. How do we increase the dose safely? How do we titrate?
Well, you don't just pick a number out of thin air. You look at the total opioid they've actually used in the last 24 hours, including all those breakthrough doses they took.
Okay.
Then if you review it and their pain really isn't controlled well enough, the source material tells us there's a calculated jump you make. You increase the total daily dose by 30 to 40%.
30 to 40%. That feels quite specific.
It is, and it's deliberate. That 30-40% increase, it's big enough that you should see a real clinical difference, a noticeable improvement in their pain. But it's also small enough that you can manage and kind of anticipate the increase in side effects, things like constipation or maybe feeling a bit fuzzy-headed. It keeps things on a controlled upward curve.
That makes complete sense.
Wow.
It's controlled escalation, not just guessing. Now, something that often causes, panic maybe for GP trainees starting morphine is the side effects right at the beginning, especially drowsiness. We need to tackle that anxiety directly, don't we?
Oh, we absolutely have to. We need to normalize this. When you start morphine, patients will almost certainly feel a bit drowsy, maybe quite drowsy. But the crucial thing, the thing you need to tell the patient and their family is how long this might last. Our sources say this drowsiness can, and often does, go on for days.
Days.
Yeah, to days. But if the patient can still be woken up easily, if they can still chat a bit, that's usually just their body adjusting. It's not usually a sign they're about to overdose. The big mistake, the clinical pitfall, is stopping the morphine straight away just because of that initial sleepiness. You've got to educate, reassure them, and just monitor closely while they get used to it.
Okay, that's really important context. And while that drowsiness might get better, there's another side effect that's almost guaranteed to stick around, isn't there? Which brings us to that absolute must-do for all strong opioid prescriptions.
This is the non-negotiable. You must always prescribe laxatives when you start opioid treatment. It's not optional. Opioids, they hit the opioid receptors in the gut wall, and that slows everything down. Peristalsis drops, fluid secretion reduces. It causes constipation.
Opioid-induced constipation, OIC.
Exactly, OIC. And it hardly ever gets better on its own because it's a direct effect of the drug being there constantly, not prescribing a stimulant laxative right from the beginning. That's just... Well, it's clinically negligent, really. It leads to suffering that's totally avoidable. It's a basic safety rule. Day one. Always.
Okay, moving on from general pain. Let's tackle some specific types of pain that need a more targeted approach, starting with metastatic bone pain. This is so common in cancer patients, and it often doesn't respond brilliantly to opioids alone. Our sources lay out a really clear 3-step ladder just for this type of pain.
Right. You start, obviously, with the standard analgesia ladder. You optimize the opioids, the non-opioids you're already using. But bone pain is different, isn't it? Because it involves active processes where the cancer is actually breaking down the bone.
Yeah.
Osteolysis, that causes mechanical instability, inflammation.
Which is why opioids alone might not cut it.
Precisely. So step 2 is critical.
Yeah.
You introduce bisphosphonates.
Bisphosphonates. Okay, they're not painkillers in the usual sense. How do they help with the pain specifically?
Well, they work by strongly inhibiting the cells that break down bone, the osteoclasts.
Wow.
By stopping or slowing down those osteoclasts, the bisphosphonates reduce that destructive process happening right at the bone site. And that directly dials down the inflammation and those analytic pain signals. So they're essential, really, as a non-analgesic add-on to slow things down at the bone level and ease the pain burden.
And what if the pain is still really bad, even after maxing out the standard painkillers and adding the bisphosphonate?
Then you escalate to step 3. Radiotherapy.
Okay.
Palliative radiotherapy gives you targeted local control. It physically stops the tumor growing or destroying bone in that specific spot, and that often gives significant pain relief, sometimes quite quickly, maybe within days. We shouldn't forget radiotherapy. It can be a highly effective, relatively low-burden treatment when systemic stuff isn't controlling localized bone pain.
Good point. Okay, let's switch tack completely. Oral pain. Seems simple? Maybe, but it can be absolutely devastating for a patient. Affects eating, drinking, talking. The sources make a really neat distinction here, treating it differently based on whether the pain is localized or diffuse.
Yeah, that distinction tells you what kind of preparation to use. If the pain is like localized, say, just one ulcer or a patch of thrush or one specific sore spot, you want something you can apply precisely, topically.
Right.
So your options there are things like choline salicylate gel, benzetamine spray, or maybe lidocaine gel or spray. These let the patient put the drug right where it hurts, get the maximum concentration there for quick local numbing.
But what if it's more widespread, like, say, mucositis after chemo, where the whole mouth lining is sore, diffuse pain?
Then you need something that can cover that whole area. So you'd shift to something like benzetamine mouthwash. It's got analgesic and anti-inflammatory effects, and swishing it around coats the whole mouth. But here's where it gets really interesting. The sources also mention morphine for diffuse oral pain.
Wait, morphine?
Yeah.
As a mouthwash? Even if they're already on morphine systemically?
Exactly, because the goal here is local effect, not systemic. You use a very low concentration of IR morphine solution, often just mixed with a bit of water or another vehicle, and the patient swishes it around their mouth for maybe a minute, then spits it out.
Huh?
The opioid receptors in that inflamed mouth lining, they're really sensitive. So this technique can give rapid local pain relief right on the sore tissues, often without adding much to their overall systemic opioid load. It's quite specialized, but yeah, very effective sometimes.
That's fascinating. A really neat trick. Okay, let's think about neuropathic pain now. That horrible burning, stabbing, electric shock type pain. It often laughs in the face of standard opioids. because it's coming from damaged nerves, not the usual pain receptors.
Yeah, this needs different drugs, ones that calm down those hyperexcitable nerve membranes. We rely on that established trio, don't we? Amitriptyline, gabapentin, and pregabalin. Amitriptyline, being an older tricyclic antidepressant, it's often first line. It works well, it's cheap, and particularly useful if the pain's worse at night because it can make people a bit drowsy, which might actually help them sleep.
But what's the big downside with amitriptyline? Why might we choose gabapentin or pregabalin instead?
It's those anticholinergic side effects, really. Dry mouth, blurred vision, constipation, maybe confusion or difficulty peeing. They can be really troublesome, especially for older patients or those who are already quite frail.
Yeah, you don't want to add to their burden.
Exactly. So that's when the gabapentinoids, gabapentin and pregabalin, often become the better choice. They work differently on calcium channels in the nerves, calming down that overactive signaling, and generally they tend to have a better side effect profile for older people.
Okay. And the critical reminder here, especially for the GP trainee juggling everything, don't just assume the pain is only because of the cancer. Always check for other causes you might be able to fix.
Oh, absolutely. That's just fundamental good practice, isn't it? Whatever the main diagnosis is. Even in palliative care, our source specifically flags up checking for and treating underlying causes like low B12.
All right, B12 deficiency.
Yeah, because B12 deficiency can cause peripheral neuropathy all by itself, totally separate from the cancer. Or it can make neuropathy caused by chemo much, much worse. A quick blood test, maybe a simple B12 injection, it could make a surprising difference to someone's quality of life. We mustn't overlook these basics just because the overall picture is complex.
Good reminder. Okay, let's quickly touch on two other specific pain types. First, bowel colic, that cramping, gripping, wave-like pain, often from some kind of blockage or irritation in the gut.
Right, for bowel colic, you need an antispasmodic, something that acts directly on the smooth muscle in the gut wall. And the specific drug choice here is hyoscine butyl bromide.
Butyl bromide, not hydrobromide.
Exactly. And this is one of those high-yield distinctions you just have to memorize for exams. The sources are really clear. Use butyl bromide for gut spasm. It works mostly peripherally in the gut. Hyoscine hydrobromide crosses into the brain more easily, so it's often used more for drying up secretions, but you risk more confusion with it. Knowing butyl versus hydro is a classic test point.
Got it. Butyl for bowel. Okay. And finally, muscle pain could be ongoing stiffness, could be sharp spasms.
Yeah, you need a mix of approaches here. Start non-pharmacologically, definitely. Physio is vital for keeping function. Heat pads can give local comfort. 10NS machines, using electrical pulses, can sometimes disrupt the pain signals.
And drug-wise.
If the spasm is really bad, you reach for muscle relaxants. The source lists benzodiazepines. They relax muscles through their effects on the brain, and they often help with anxiety too. And also baclofen, which is specifically designed as a skeletal muscle relaxant. It works centrally on GABA receptors to damp down that muscle tone and excitability.
Okay, this next bit needs full concentration. This is probably the single most critical safety point in strong opioid prescribing, especially for you as a GP trainee managing patients with multiple health problems. It's the link between morphine and kidney function. This is where being vigilant literally saves lives, prevents awful suffering.
Couldn't agree more. This is absolute non-negotiable clinical knowledge. The critical number, the safety threshold you have to burn into your memory is this. Morphine is absolutely contraindicated if the patient's kidney function, their estimated glomerular filtration rate, or eGFR, drops below 30 millimeter.
Below 30, full stop.
Full stop. You do not start morphine, and you do not continue morphine if someone has severe kidney impairment. Period.
Why morphine specifically? Lots of palliative patients are on it. What's actually happening in the body when the kidneys aren't working well?
It's all about how morphine is broken down, its metabolism, and what those breakdown products, the metabolites, actually do. This gets tested a lot. Morphine gets processed mainly in the liver into two main compounds: morphine 6-glucuronide, M6G, and morphine 3-glucuronide, M3G.
Okay, M6G and M3G, let's take those one by one.
Right. M6G is the real troublemaker. It's actually a stronger painkiller than morphine itself, believe it or not. But crucially, it's also highly toxic. Now, in someone with healthy kidneys, M6G gets flushed out quickly. But if that eGFR drops below 30, M6G starts to build up. It accumulates.
And that accumulation is dangerous.
Very dangerous. It leads to progressive deep sedation. It can cause life-threatening respiratory depression, stopping breathing, and it causes neurotoxicity. That shows up as muscle twitching, called myoclonus, or even seizures.
Okay, so M6G is the potent, toxic one that builds up. What about M3G?
M3G isn't really a painkiller, but it is a potent neuroexcitatory metabolite. So while it's maybe less immediately dangerous than M6G, when it builds up, it makes the neurotoxicity worse. It contributes to delirium, agitation, that whole horrible picture we call opioid toxicity, and it just creeps up over days because the kidneys can't clear these active compounds, leading to this dangerous overdose state, even if the patient is on what was previously a stable dose.
Wow. Okay, so that's the why behind that strict eGFR less than 30 rule. So if we spot a patient whose kidneys are failing, we have to switch them off morphine immediately. What are the safe alternatives? Which opioids don't have this metabolite problem?
We've got 3 standard safe go-to options for moderate or severe pain when kidney function is poor: oxycodone, buprenorphine, and fentanyl.
Okay, oxybuprenofentanil.
Yeah. And the reason they're safer is because their main metabolites are either inactive or they're much easier for poorly functioning kidneys to get rid of.
Let's touch on each quickly. Oxycodone is often the first one people think of switching to.
Yeah, oxycodone gets metabolized to oxymorphone, which does have some activity, but the buildup is much less of a problem in mild or moderate kidney failure compared to M6G. You still need to be careful, obviously. Start low, go slow with titration, but it's a much, much safer bet than morphine.
And buprenorphine and fentanyl, they often come as patches, right?
Yeah.
They do, and they're excellent choices because they're mainly broken down by the liver into inactive stuff. That means kidney clearance isn't the main way the active drug or problematic metabolites get removed. So buprenorphine, often as a patch, is great for stable background pain. Fentanyl, too, because it has a really short half-life and inactive metabolites, it's a real staple for patients in renal failure.
But our source material highlights one opioid as having the best renal profile, often kept for more specialist situations.
Ah, yes. That would be alfentanil. You tend to see alfentanil used more in specialist palliative care units, maybe hospice settings, or even critical care. It's metabolized incredibly quickly into completely inactive metabolites, and it gets cleared very fast, largely bypassing the kidneys for getting rid of active compounds. So theoretically, it's the safest option when kidney function is really, really poor. It gives you the most control with the least risk of toxic buildup.
So for the GP trainee listening, the take-home message here is huge. You see a patient on morphine, maybe they've become suddenly drowsy or agitated or they're twitching, especially if they're a bit dehydrated or unwell. Your first thought must be, check the kidney function. Check the eGFR.
Absolutely. Bang on. If that eGFR is low, you've likely found your answer, and you have to act fast, switch the opioid safely. Knowing that hierarchy morphine is out below 30, then oxybuprenofentanil are your standard safe swaps, and alfentanil is kind of the gold standard for severe impairment. Knowing that is just.
Well, it's a hallmark of safe, high-quality palliative prescribing.
Right. Let's shift focus now to managing symptoms other than pain. We'll start with that really common issue we mentioned earlier, opioid-induced constipation. We said you have to prescribe a laxative from day one. Now, let's detail that clear escalation plan for when the first-line treatment isn't quite enough. It's actually really logical, step-by-step approach based on how the drugs work. Yeah, it's logical combination therapy, isn't it? Because, oh, I see, the problem is twofold. Things aren't moving well, reduced peristalsis, and the stool itself gets hard because fluid is reduced. So you need to target both problems.
Okay, so step 1, we start with a stimulant.
Usually senna, yeah. Senna works by stimulating the nerves in the colon wall, which makes the gut contract, increases peristalsis. It basically forces the gut to move. And crucially, remember we talked about increasing the opioid dose by 30–40% for pain.
Yeah.
Well, as the opioid dose goes up, the dose of the stimulant laxative usually needs to go up too, proportionally, because the constipating effect is dose-dependent. More opioid means more slowing, means you need more stimulant.
Okay, that makes sense. But just making the gut move might not be enough if the stool itself is like rocks, right? So what's step 2 if senna's getting things moving but it's still really hard and difficult to pass?
Right. If the movement's happening but the consistency is the issue, you add a stool softener. The source specifies Docusate. Docusate acts like a detergent, basically. It lowers the surface tension of the stool, letting water and fat get in, which softens it up. That makes the movement the senna is creating much less painful and more effective. So you combine the actions, stimulate plus soften.
Got it. Stimulate with senna, soften with Docusate. And what if even that combination isn't cutting it?
Step 3. You add an osmotic laxative. Lactulose is the typical one. Osmotic agents are basically sugars that your body can't absorb. They stay in the bowel and draw water into the colon by osmosis.
Pulls water in.
Exactly. That significantly increases the amount of fluid in the bowel, which softens the stool even more, and also creates a bigger, bulkier mass, which itself provides a stronger signal for the bowel to empty. So the full escalation ladder is start Senna, add Docusit, add Lactulose.
That progression really shows you need different types of drugs working together to beat the strong constipating effect of opioids. Okay, now let's think about the other end. Literally, if the patient ends up with impacted stool in the rectum, the treatment choice depends on what you actually feel on examination, right?
Yes. The source gives us specific choices based on what you find during a digital rectal examination, a DRE. If the stools feel soft but just aren't coming out, you'd use Bisacodyl suppositories. They give a strong local stimulation right in the rectum to trigger evacuation.
Okay.
If the stools feel hard, you'd use glycerol suppositories. Glycerol acts mainly as a local lubricant, and it also draws a bit of water in locally just to help things slide out more easily. And if the stool is really, really hard, like proper impaction that needs more help to break up, then you have to go for an enema, often a microenema first, to get some fluid in there and physically break up that hard mass.
Okay, clear steps depending on consistency. Let's switch gears completely now to emotional and psychological symptoms. Let's focus on anxiety and that difficult state of terminal restlessness. The choice of drug here, particularly benzodiazepines, seems really dependent on the patient's overall situation, their prognosis.
Yeah, this is a great example of really nuanced palliative prescribing. If someone has long-standing pre-existing anxiety, the right approach is still probably a longer-term strategy, maybe an SSRI antidepressant. That's targeting the underlying issue.
Right, but what if the anxiety is sudden? It's situational. Maybe they're scared about dying or they've just had some bad news.
Then you need something faster acting for that acute distress. That's where lorazepam comes in. It's a benzodiazepine you can often give sublingually, under the tongue, or orally. It gives pretty quick relief from that situational anxiety, that acute fear, without necessarily knocking them out completely like some other agents might.
Okay, lorazepam for acute fear. But what if the patient is right at the very end, last hours, last days, and they're experiencing that profound terminal anxiety or restlessness? The treatment steps up again, doesn't it?
It does. That's when we reach for midazolam.
Midazolam.
Midazolam is a very fast-acting benzodiazepine. It's often given via continuous subcutaneous infusion, maybe in a syringe driver. The specific goal here is ensuring comfort, eliminating that deep existential distress that can happen right at the very end of life. It provides the sedation and anxiety relief needed for a peaceful passing.
Okay, let's tackle breathing problems at the end. Specifically noisy, wet secretions, sometimes called the death rattle, which can be incredibly upsetting for families to hear. We need drugs to dry those secretions up, the anticholinergics.
Yes, and knowing this list of anticholinergic agents is absolutely core, high-yield stuff for exams. We've got hyoscine butyl bromide.
One for bowel spasm.
The very same. We've also got hyoscine hydrobromide and glycopyrronium bromide. They all work the same basic way, blocking acetylcholine receptors, which reduces saliva and bronchial secretions. But understanding the differences between them is really important for GP trainees.
Can you break down the pros and cons, particularly thinking about side effects like confusion?
Sure. Hyoscine hydrobromide, while it works, gets into the brain quite easily. It crosses the blood-brain barrier. That means there's a higher risk of central side effects, confusion, delirium, agitation, which is exactly what you don't want near the end of life.
Right.
Hyoscine butyl bromide is less likely to cross that barrier, so it's generally safer from a brain point of view, and it's often the standard first choice for secretions. However, glycopyrronium is often the favorite for specialists. Why? Because it's what's called a quaternary ammonium compound. Its chemical structure physically stops it from crossing the blood-brain barrier at all.
So virtually no risk of central confusion from it.
Exactly. It gives you the drying effect without the delirium risk. It's the cleanest agent, if you like, purely for secretion control.
Okay, that's a really useful distinction. Sticking with restlessness, but maybe more general restlessness or delirium, the sources make a really crucial point about timing when choosing between two main drugs, haloperidol versus midazolam.
Yeah, the choice here hangs entirely on the patient's prognosis, how long we think they have. Haloperidol, which is an antipsychotic, is the go-to drug for managing general restlessness or delirium if the patient is not right at the end of life, not imminently dying.
Okay.
The goal then is often to try and clear their thinking a bit, manage the agitation, especially if there might be a reversible cause for the delirium. But if the patient is in the last days or hours of life, then comfort, immediate anxiety relief becomes the absolute priority over trying to clear their head. And that's when we switch to midazolam for rapid terminal calming.
Prognosis dictates the choice. Makes sense. Okay, let's move to a symptom that might not be life-threatening but can drive patients absolutely mad. Hiccups. The sources give a surprisingly detailed multi-step approach, which kind of tells you how persistent and annoying this problem can be.
Oh, it's a great test of knowing a bit of everything, isn't it? From simple tricks right up to specialist IV drugs. You start with the non-drug things, basically trying to interrupt the reflex arc involving the phrenic nerve that controls the diaphragm.
Like what?
Simple stuff. Sips of water, sipping icy water, holding your breath, or breathing into a paper bag that increases CO2 levels, which can sometimes break the cycle. And there's even a specific technique mentioned. Gently rubbing the soft palate way at the back of the roof of your mouth with a swab. That stimulates a different nerve, the glossopharyngeal nerve, and can sometimes stop them.
Interesting. Okay, if those tricks don't work, we move on to simple over-the-counter things or standard GP treatments.
Yeah, then you start thinking, could it be irritation from the stomach triggering the diaphragm spasm? So OTC options might be a peppermint water or an antacid that contains simethicone. If you suspect reflux, G or RD is the cause, you try a PPI, a proton pump inhibitor.
Okay.
You also consider prokinetics drugs like metoclopramide or domperidone. They help empty the stomach faster, which might stop stomach contents pressing upwards on the diaphragm.
Right. And when do things escalate to more specialist territory? For really stubborn hiccups.
That's when the standard stuff has failed, or maybe if you know the cause is something more central in the brain or a structural problem. The source lists nifedipine, a calcium channel blocker, or baclofen, the muscle relaxant we mentioned earlier, as specialized options. And interestingly, it specifically flags dexamethasone if the hiccups are thought to be caused by liver metastases, liver cancer spread.
Dex for hiccups from liver mets. Why?
The idea is that the steroid reduces the swelling or inflammation around the liver tumors, which might be pressing on or irritating the diaphragm or the phrenic nerve pathway nearby. So shrink the inflammation, stop the trigger. Favor. And then the absolute last resort, for really intractable cases, is listed as chlorpromazine the faith. That's an older antipsychotic that has strong anti-hiccup effects, but it's definitely specialist territory, usually given in hospital.
Okay, comprehensive. Finally, for this section, let's briefly touch on fatigue and breathlessness. For that profound fatigue that sometimes hits palliative patients, where you can't find an obvious cause, what's the go-to drug?
If you've checked for the usual suspects, no anemia, thyroid's okay, no infection, then dexamethasone is often the treatment tried. Steroids like Dex don't cure the underlying cause of the fatigue, obviously, but they can often give a temporary, sometimes quite remarkable boost in energy, mood, and appetite. It can significantly improve quality of life, even if just for a while.
Okay, Dex for unexplained fatigue. And managing this sensation of breathlessness, it seems like non-drug approaches are really key here first.
Oh, absolutely. You rely heavily on simple things first to try and reduce how breathless the person feels. Like using a fan blowing cool air directly onto the face actually stimulates a nerve, the trigeminal nerve, and that seems to lessen the perception of breathlessness.
Just a simple fan?
Yeah. Also teaching pacing and relaxing techniques, general relaxation, and crucially, the source mentions Buteyko breathing. Now, this isn't just about breathing slowly.
Can you explain Buteyko a bit more? How does it help with palliative breathlessness?
Right. The Buteyko technique basically trains people to take shallower breaths, breathe more slowly, and really importantly, to breathe through their nose. What happens often, especially if anxiety is driving the breathlessness or in conditions like advanced COPD, is that people accidentally hyperventilate.
Breathe too much.
Yeah, too fast, too deep. That blows off too much CO2, makes them hypocapnic, and paradoxically, low CO2 can actually increase the feeling of breathlessness and anxiety. Buteyko aims to fix that breathing pattern, make it more efficient, reduce that feeling of air hunger, and give the patient a sense of control back.
Okay, useful technique. But if non-drug methods aren't enough, what's the drug ladder for managing breathing distress?
You treat the cause if you can. So salbutamol, if you hear an actual wheeze or, they have bronchospasm, for that awful feeling of terminal shortness of breath, SOB, the gold standard is morphine.
Morphine again. How does it help breathing?
It works centrally in the brain. It reduces the respiratory drive slightly, but more importantly, it lowers the brain's perception of being breathless. So the patient feels more comfortable, less distressed by it, even if their oxygen levels haven't actually changed much.
Okay.
Then, if anxiety is clearly making the breathlessness worse, you'd add midazolam, like we discussed. And finally, if it's noisy, wet breathing because of secretions, you use those anticholinergic drugs we just covered, glycopyrronium, hyoscine butyl bromide.
Right. Now we need to switch gears completely. We're moving into the really high-stakes, time-critical stuff, oncological emergencies. These are the situations where you need instant recognition, high-dose steroids, quick referrals, the kind of scenarios that really test your confidence, both for exams like the AKT and definitely in real clinical practice. Let's start with that crucial neurological distinction, spinal cord compression versus cauda equina syndrome.
Yeah, this is basically about anatomy dictating the name, although the immediate management is often exactly the same. The source material draws a clear line. Spinal cord compression is when the spinal cord itself is being squeezed, and that typically happens at level L2 or higher up the spine.
Okay, L2 and above is cord compression.
Right. Cauda equina syndrome happens below L2. Down there, the spinal cord is ended, and you've
Yeah.
just got that bundle of nerve roots trailing down, looking like a horse's tail, the cauda equina. So compression there affects those nerve roots.
But whether it's the cord or the cauda equina being squeezed, if a patient presents with those worrying symptoms, new leg weakness, numbness, maybe problems with their bladder or bowel control, that triggers an immediate, potentially function-saving drug treatment, doesn't it?
Absolutely. That is the critical decision point. You suspect compression. You give high-dose dexamethasone immediately. The aim is to shrink the swelling, the edema, around the tumor that's pressing on the nerves. That buys time. It might preserve nerve function before they can get surgery or radiotherapy.
And the dose is high.
Yes, high dose. Dexamethasone, specifically 8 milligrams to 16 milligrams, straight away. You'll order the urgent MRI scan to confirm it, of course, but you do not wait for the scan result before giving the steroids. Then it's an immediate referral, usually to the spinal surgeons or neurosurgeons. Time is nerve function here. Absolutely critical.
Okay, moving to a vascular emergency. Superior vena cava syndrome or SVC syndrome. Can you quickly outline the mechanism, what's happening, and those classic signs that should make you think of this diagnosis straight away?
Sure. SVC syndrome, it's caused by something pressing on the outside of the superior vena cava, that big vein bringing blood back from the head, neck, and arms to the heart. Usually it's a tumor in the chest, in the mediastinum, often lung cancer or lymphoma that's squashing the vein shut.
So the blood can't get back.
Exactly. The pressure builds up upstream, causing congestion in the areas drained by the SVC. And the classic signs are pretty unmistakable. You see a swollen face, sometimes called facial plethora, maybe puffy eyes. Patients often feel short of breath. And the key sign really is a fixed raised JVP, jugular venous pressure. You look at the neck veins, they're bulging, and importantly, the level doesn't change much when they breathe or sit up. It's fixed. It might not even pulsate properly because the blood just can't drain down into the heart easily.
Okay, swollen face, fixed raised JVP, shortness of breath, and the management plan. It's got a few parts, hasn't it?
Yeah, it's multi-pronged. First, you want to reduce the symptoms, the swelling, so again, dexamethasone if they're symptomatic. Second, you need to relieve the blockage quickly. Often, the patient will go to professional radiology for stenting of the SVC. They put a metal tube inside the vein to prop it open and get the blood flowing again immediately.
Okay, stenting for immediate relief.
Yeah. And third, you need to treat the underlying cause. So that means chemo or radiotherapy, depending on what type of cancer it is, to actually shrink the tumor that's causing the obstruction in the first place.
Got it. Okay, next up, neutropenic sepsis. Probably the most feared acute complication after chemotherapy. We need to be absolutely crystal clear on the definition, the criteria, and the fact that you have zero time to waste.
Absolutely. The defining criteria are precise, and they come up in exams all the time. You need two things. Neutrophils, the absolute neutrophil count must be less than 0.5, that's critically low, and the temperature must be over 38 degrees Celsius.
Neutrophils 0.5 and E-temp 38, both needed.
Both needed. If a patient meets those two criteria, they have neutropenic sepsis. Full stop. You treat it as a medical emergency because their immune system is essentially wiped out.
And the timing is often quite predictable, isn't it? When it's likely to happen after chemo.
Yes. Typically, the onset is about 1 to 2 weeks after they've had their chemotherapy dose. That's when the bone marrow suppression, the chemo's effect on blood cell production, hits its lowest point, called the nadir. Knowing this timing helps us warn patients when to be extra vigilant, when to seek help immediately if they get a fever.
Okay, let's talk through that antibiotic ladder. There's a clear progression.
Right. Some patients might be on ciprofloxacin as prophylaxis to try and prevent it during that high-risk nadir period. But once they actually are septic, by those criteria, you need immediate, broad-spectrum intravenous antibiotics. The standard first-line treatment is tazocin, that's piperacillin with tazobactam,
Why tazocin first?
because it gives really good coverage against the most likely culprits, especially nasty gram-negative bacteria like Pseudomonas aeruginosa, which love to cause trouble in immunocompromised patients.
Okay, but what if tazocin isn't working? What makes you step up the treatment?
If the patient isn't getting better within, say, 48 to 72 hours, or if they were incredibly sick right from the start, you have to escalate. You don't wait. You'd move to something like meropenem, which is a carbapenem antibiotic with an even broader spectrum of cover. Or you might add vancomycin to the tazocin meropenem, especially if you suspect a resistant gram-positive bug like MRSA, maybe from a central line infection. The key is don't delay escalation if they're not responding.
Right. And what if they're still not improving after nearly a week, despite being on these really powerful broad-spectrum antibiotics? What should you be thinking then?
That's the big trigger point to suspect a fungal infection. If there's no clinical improvement after about 6 or 7 days, fungal sepsis becomes a strong possibility. The next mandated step is to get fungal cultures done, try and identify the specific fungus, and start appropriate antifungal therapy straight away, drugs like caspofungin or amphotericin B.
Okay, need to think fungus if antibiotics aren't working after about a week. Got it. Now, hypercalcemia, high calcium levels, another common metabolic emergency in cancer, often linked to bone mets spreading to bone, or sometimes the tumor making hormones. What are the classic symptoms we should look out for?
The symptoms can be really varied, which is why people use that old mnemonic, moans, bones, groans, and psychiatric overtones.
Right?
Moans refers to things like fatigue, confusion, the psychiatric or neurological changes. Bones obviously refers to the bone pain from the underlying cancer. And groans covers the gut symptoms. Constipation is very common, but also abdominal pain. Our sources specifically mention abdominal pain and joint pain too.
Okay. And if someone presents with acutely high calcium, what's the immediate management, the stepwise plan?
It's got 3 main parts for acute management. First, fluids. Aggressive 5E fluids, usually normal saline. This helps rehydrate the patient, dilute the calcium in the blood, and encourages the kidneys to flush more calcium out.
Okay, fluids first.
Second, if you need to bring the calcium down quickly, maybe in the short term while other treatments kick in, you can use calcitonin. Calcitonin works fast to stop bone breakdown and boost kidney excretion of calcium, but its effect doesn't last very long.
So calcitonin for a quick fix.
Yeah, a temporary rapid lowering. Third, the definitive treatment, the thing that gives longer-term control, is an IV bisphosphonate, usually zoledronic acid or pamidronate. These are powerful drugs given intravenously that really shut down those osteoclasts, the cells breaking down bone, effectively turning off the tap, releasing calcium from the bones. Then, once they're stable, they obviously need referring back to their oncology team.
Makes sense. Fluids, calcitonin, Sufi, bisphosphonate. Okay, finally in this section, a really difficult topic, but one we have to be prepared for. Catastrophic hemorrhage, a massive bleed near the end of life. This demands calm, practical steps, focusing on dignity.
Yeah, preparation is absolutely key here. Wards or teams looking after patients at high risk should have a crisis kit ready, usually containing the necessary medications, and crucially, dark-colored absorbent materials. When a massive bleed happens, the priority instantly shifts away from trying to stop the bleed or save life towards ensuring comfort and maintaining dignity.
What are the immediate actions? What do you actually do?
The immediate actions are all about reducing distress. You give benzodiazepines, oxymetazolam, maybe subcutaneously for immediate sedation, to reduce the terror and agitation for both the patient and anyone else present, like family.
Okay, sedation first.
Yes, you use dark towels. This sounds simple, but it's critically important. Dark towels absorb the blood, but they make the visual impact much less shocking, less distressing for everyone, compared to bright red, blood-soaking white sheets. If it's possible and seems appropriate, you might apply gentle pressure to the bleeding site. But perhaps the single most vital instruction, often stressed in protocols, is do not leave the patient alone. Your calm presence provides comfort, reduces fear during what is an incredibly frightening event.
Right, to wrap up this really intensive review, let's just quickly focus on some pattern recognition for chemotherapy side effects. For exam prep, you as a GP trainee really need to be able to link specific high-risk chemo drugs to the main organ system they tend to damage. It's kind of pure pattern matching, but knowing these links helps you anticipate problems and avoid missing serious issues.
Yeah. This is about knowing the specific toxicities that make certain drugs particularly dangerous, the ones that get tested because they're serious. For example, doxorubicin. You hear doxorubicin, you should immediately think heart. It carries a significant risk of causing heart failure.
Cardiotoxicity.
Exactly. It's a known cardiotoxin. Patients getting it need their heart function checked regularly, often with echo scans, throughout their treatment.
Okay, doxorubicin, heart. What about docetaxel? What's the big blood-related toxicity we need to watch for?
Docetaxel is strongly associated with neutropenia, that severe drop in neutrophil counts caused by bone marrow suppression, which, as we just discussed in detail, puts the patient at high risk of neutropenic sepsis. So you give docetaxel, you know you need to be vigilant about monitoring their blood counts afterwards.
Docetaxel, neutropenia, okay, and methotrexate. That one's kind of notorious for potentially causing long-term damage in a couple of major organs, right?
Yes, methotrexate, especially if used in high doses or for long periods, is linked to both lung fibrosis and liver fibrosis. It can cause scarring in those organs. It's a systemic toxin, so patients on it need monitoring lung function tests, liver blood tests, to try and catch these potentially irreversible problems early.
Methotrexate, lung and liver fibrosis.
Got it.
Okay, let's finish with vincristine. Its side effect profile is quite distinctive, isn't it?
Yeah.
Because it tends to spare the bone marrow, but really goes after the nervous system and the gut. There's a classic triad of side effects to remember.
Yeah, the vincristine triad is highly testable because it's so unique. First, the sort of good news part. It causes minimal bone marrow suppression, which makes it useful sometimes in combination chemo regimens where you want to avoid hitting the blood counts too hard.
Okay, minimal marrow suppression.
But the downsides. It's notorious for causing peripheral neuropathy specifically, that pins and needles feeling, sensory neuropathy. It can be really severe and often limits how much drug you can give.
Pins and needles.
And the third part of the triad, the most concerning acute one probably, is paralytic ileus. It can cause the bowel to just stop working, become paralyzed because the drug is toxic to the autonomic nerves supplying the gut. That leads to severe constipation, abdominal pain, vomiting, linking right back to why managing bowel function is so critical in these patients.
Vincristine, minimal marrow suppression, pins and needles, paralytic ileus. Got the triad, hashtag tag outro. Wow.
Yeah.
That was an incredibly detailed and I think really high-yield deep dive. We went all the way from the nuts and bolts, the arithmetic of pain management, that specific 30-40% titration rule, right through to the absolute life-saving knowledge you need for those oncological emergencies. Knowing the difference between giving dexamethasone for cord compression versus giving it for fatigue, or knowing exactly which opioid to switch to if someone's kidneys aren't working, those are the details, aren't they?
Yeah.
That's what defines safe, really competent practice.
And that level of detail is crucial. We really hammered home why you absolutely have to know those specific drug profiles, why morphine is a definite no-go if the eGFR is under 30 because of those dangerous M6G metabolites, and why drugs like alfentanil or glycopyrronium for secretions are preferred in certain high-risk situations. It's applying the pharmacology directly to keep patients safe and comfortable. You should now feel armed with protocols that will hopefully stand up, under the pressure of an exam situation, but also when you're facing the complexities on the ward or in the community.
Absolutely. Now, as we finish up, let's leave you, the listener, with a final thought. It kind of brings together the two big themes from today's sources. On the one hand, symptom management, comfort care, and on the other, that really aggressive emergency treatment. We spent a lot of time on the protocols for neutropenic sepsis needing maybe a week of intense antibiotics, and spinal cord compression needing immediate high-dose steroids, urgent referrals.
Yeah. And this raises a really profound question, doesn't it? A clinical challenge, an ethical one too, for you as the clinician. Given how intense, how aggressively life-prolonging the management for these oncological emergencies often is, where do we draw the line? Especially as generalists, where's the line between aggressively investigating and treating everything and respecting the patient's overall palliative goals? Is there a point where maybe we treat the emergency symptoms, the pain, the nausea, but we consciously decide not to push for the surgical referral or maximum ICU support because that wouldn't align with the patient's ultimate wish for just pure symptom relief, for dignity at the end?
Yeah.
That fine balance, that often really difficult judgment call between aiming for cure or prolongation and aiming purely for comfort. That's maybe the ultimate test of advanced palliative care thinking.
A really profound question, and one that just highlights how complex this area of medicine is.
Right.
Thank you so much for joining us for this really crucial deep dive into palliative care essentials.
Yeah, thanks for listening. Stay safe out there and keep honing that clinical judgment.
We'll catch you next time on The Deep Dive.